Right, let's give it a start then. So, hello everybody. My name is Jon Aron, a consultant of intensive care medicine at St George's Hospital in London. Wow, I'm on sabbatical at the moment. Thank you very much for asking me to talk about pericardial collections as part of your ongoing FUSIC HD series. So I think kudos for getting that up and running. So just for those of you who joined, I've posed some questions to get your brains warmed up for the onslaught that you're about to receive. But we will move on to what I hope to chat to you about, which is relevant anatomy, but to be honest, that's really boring. Physiology, which I'm a big fan of, and I'll linger slightly longer on. Spotting a pericardial collection is actually very, very easy. So again, not going to chat too much about that. What's much more interesting at this stage, at FUSIC HD level, is actually spotting a pericardial collection and understanding what hemodynamic significance it poses. Now, that is a really, 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 really tough thing to do. And so we'll spend most of the time talking about the clinical context of what to do when you spot a little bit of fluid around the heart. You may decide, the royal we, that the hemodynamic significance of the given pericardial collection is actually not that significant. But that's not to say it won't be in the future. So you have got to predict the future and understand how, under certain circumstances, the situation could change. So we'll talk a little bit about that. And then, as is becoming a theme with these talks, I'll talk about all the ways I've messed things up and how maybe you could learn from those and some take-home messages. It's probably best, I can't really see the chat, so it's probably best to just post messages there or save your questions to the end if you can. If there's something burning, like your house is on fire, then please let us know. So just to reiterate, the key components, the key message of focused echo, the whole reason we can condense echocardiography into a shorter training program with a shorter logbook with a series of clinical questions is because you are already highly trained doctors in the first place. So you are uniquely positioned to have an accelerated echo accreditation process because you are the one who understands the clinical history, have examined the patient, understands the trajectory of the patient, and already have an established idea of what's going on, and then try and confirm it either by ruling in or by ruling out certain key pathologies with your echocardiography. So the important thing to say is a patient, an individual who spent 2 to 8 years doing nothing but echo actually may be in a worse position to work out the hemodynamic effects of a tamponade than you as an individual doing this for 1 year, but who has all the medical knowledge underpinning everything. So this is a really, really good example where it really pays for clinicians to do echocardiography. Like I insinuated earlier, the anatomy is really boring. At the end of the day, it's a rigid sac that surrounds the heart. I mean, there's 2 layers to the sac. There's parietal or visceral layer, and it reflects off the great vessels. But it effect is a big bag. Now, the big bag, the interesting thing about it is that it creates a finite volume within it. And really, that means if it gets filled up, something else gets squished, which is the whole kind of underlying mechanism of tamponade. So we'll talk about that a bit more in a moment. Now, over time, if the volume builds up gradually, and the pressure builds up gradually, yes, indeed, the sac can stretch. That, of course, I'm talking about a chronic effusion, can result in a large volume but low pressure effusion, which you need to be able to spot. However, acute effusions that accumulate rapidly without allowing time for this bag to stretch will exert a large pressure with a relatively small volume, and that should be relatively obvious. So anatomy is boring, really, once you understand those concepts. So I'll talk a bit about physiology, and I really do apologize. I ran out a bit of time doing this talk. I hope you forgive how basic my diagrams are. But I really want to talk about the differential pressures across a wall. how the pressure changes over the cardiac cycle, and how the pressures change over the respiratory cycle. So 3 things to really focus on if you really want to understand what's happening when you echo these people, which again, I would advocate doing. So this is a really, really bad diagram. There's a wall there which can move left or right depending on the pressure applied on either side of it. So pretty straightforward stuff. So for example, if we increase the pressure in this compartment, this wall will move this way until the pressure is equalized, and therefore the pressures are now the same across both sides of the wall because the volume on the right has been compressed, so the pressure goes up. I hope that's pretty clear. Now, clearly, you remember your GCSEs and A-level physics and chemistry the same as I do. There's different ways to increase pressure, heat or solutes, all kinds of stuff. In this case, of course, we're talking about a physical compression, a reduction in volume. So let's take that to look at a familiar topic called pulmonale. So when you have a PE, for instance, you know that your right ventricle expands. Because the fibrous sac of the pericardium doesn't allow an increase in volume within its sac, therefore something's got to give. And if it's the right ventricle expanding, the left ventricle gets squished. In fact, this is the process that causes eventual cardiac arrest. The left ventricle doesn't fill and is empty, and therefore the patient has a PEA arrest. Okay, so let's talk about tamponade. So you have pressure within the pericardium, most commonly caused by volume accumulation, which then causes an increase of pressure within that pericardium. Now, the lowest pressure chamber throughout most of the cardiac cycle is the right atrium. So that is the chamber that receives venous flow. And of course, if you are healthy like we are here, the right atrial pressure should be as low as possible. Your body wants to maintain a low right atrial pressure. So it is low, and therefore any increase in pericardial pressure will cause the right atrium to collapse. That's straightforward. Now, the right ventricle chamber pressure is actually higher than that of the right atrium at certain parts of the cardiac cycle. So initially, the lowest pressure chamber collapses, and then the second lowest chamber collapses. So the right ventricle chamber will collapse later on as the tamponade progresses. Okay, well, let's think about what happens in the cardiac cycle. So let's be right atrium focused for the time being. Now, close your eyes and imagine that you are the right atrium. So during diastole, your job, and remember, diastole is a ventricle-centric term. So diastole is when there is ventricle filling. So actually, that's atrial systole, or at least some of the time it's atrial systole. So in this case, the ventricle is filling. So the tricuspid valve is open and blood is moving from the right atrium via the tricuspid valve and filling the right ventricle. I hope that's clear. So that's the process of diastole. Now, during that time with an open tricuspid valve, if the pericardium pressure is high and squishes the right atrium, that's okay. It's squishing blood through the tricuspid valve, almost assisting the right atrium to fill the right ventricle. Okay, so remember, there's early phase of ventricular filling, the E wave, and there's atrial contraction. So if the pericardium is exerting external pressure on the right atrium and squeezing it, it's actually encouraging blood through the tricuspid valve and into the right ventricle. So that's not that big a deal. And actually what you see at this time, because the tricuspid valve is open, is that this wall really does collapse. And that's quite alarming. But if you understand that this process actually might be pushing blood through the tricuspid valve into the right ventricle, maybe it's not so alarming. So the more important thing to look at is what happens during cardiac systole. Now remember, cardiac systole, a ventricle centric process, and it's what happens. The pulmonary valve is of course open and the tricuspid valve is now closed. Now the atrium is now filling because of venous pressure. So this is now when the right atrial pressure should be highest. The tricuspid valve is closed. It is now a dead end chamber in effect during cardiac systole. So you would expect the wall not to compress nearly as much as when the tricuspid valve is open. But this is the dangerous time of the cardiac cycle. So if there is collapse during ventricular systole, when the right atrium should be filling, that is a problem, because that means the right atrium is not filling, which means the right atrium is empty, which means that during diastole, the empty right atrium is then going to try and fill the right ventricle, but because it's empty, the right ventricle is empty, and therefore if the right ventricle is empty, that's going to collapse and it's going to underfill the left side of the heart, and you're going to develop a shock state. So it's a of impaired filling of the chamber. So in the right, if you're talking about the right atrium, which is the lowest pressure chamber and the one that gets affected first, if you see collapse during systole, not diastole, but systole, that is when you should get worried, because that implies that the right atrium is not filling, which means it has no volume to pass on to the right ventricle. So when you look at your image, you pause it, you scroll back and forth, and look at the chamber when the tricuspid valve is closed. Note what happens when the tricuspid valve is open, but almost always there'll be a degree of collapse when the tricuspid valve is open. That doesn't necessarily mean there's a problem. It's much more likely to be a problem if the right atrium is collapsing with the tricuspid valve closed. Let's think about what happens with the right ventricle. So same process with the pulmonary valve open during ventricular systole. If there's pericardial volume and pressure, then it might really cause the right ventricle to collapse quite considerably. Again, looking quite alarming. But again, that's potentially just assisting the right ventricle squeezing out its volume through an open pulmonary valve. That may not be the problem. The problem is much more when the right ventricle should be filling. So when the pulmonary valve is closed, what you would expect is perhaps a little bit of compression, but it shouldn't compress entirely. And if it does, that's much more worrying, because in the same respect, the right ventricle is not filling, it doesn't then fill the left side of the heart, and you develop a low cardiac output state. I hope those concepts are clear. So that's the cardiac cycle. Let's move on to the respiratory cycle. And of course, depending on how you're respiring, if it's with positive pressure ventilation or good old-fashioned swinging intrathoracic pressure, if you're spontaneously breathing, regardless, when the pressure is at its lowest, either negative if you're spontaneously breathing or less positive if you're on a ventilator, that is when the right side of the heart fills. So over the respiratory cycle, there's going to be a change in right-sided filling depending on how much intrathoracic pressure there is, i.e. the lower the intrathoracic pressure, the more filling you'd expect. The higher the intrathoracic pressure, the less filling you'd expect. So respiratory cycle. So clearly there's more blood that goes to the right side of the heart when intrathoracic pressure is low. So what you'd expect to see is if there's pericardial fluid causing an increased pressure on the right side of the heart, the time when the right side of the heart is more empty is going to be much more significant. So you're going to see, so this is when the intrathoracic pressure is low, filling, the right atrial filling is higher, and therefore it is in comparison higher than other times. So it's going to have less of a compressive effect. The pericardial collection is going to have less of a depressive effect on the right atrium during this time of the respiratory cycle. And therefore, you might see less compression during this time. And on the other hand, when there is right-sided compression because of high PEEP or high intrathoracic pressure or during inspiration, the right atrial pressure is comparatively low, and therefore the pericardial pressure is going to be comparatively high, and you're going to see more compression during this time of the respiratory cycle. So it's not good enough just to watch what happens over the cardiac cycle. You've also got to see what happens over the respiratory cycle. And we'll see another way to measure this shortly as we go on to the lecture. But you can actually witness this in two dimensions. You see the change in right-sided compression over the respiratory cycle. And if that's very prominent, then that should highlight a very significant problem for the patient. And I think this is meant to go back and forth, demonstrating what it might look like if there's a spontaneously breathing patient. Now, just to make it very clear, as you know, that there's ventricular interdependence because there's only a fixed volume of space within the pericardium. So if one chamber expands, it compresses the other and vice versa. This is the same principle with tamponade. So with a rapid effusion, because the bag hasn't had a chance to distend, a very, very small increase in fluid results in a very, very rapid increase in pressure. But with time and a slow accumulation of volume within the pericardium, the bag stretches, and therefore you can have a much larger volume, which exhibits a much lower pressure on the heart. So the volume is not the only indicator of tamponade presence or not. I hope some of that physiology is straightforward. So moving on then, a little bit about how you'd want to describe a pericardial effusion should you see one. So on the whole, these are the things that we look for. We try and describe whether it's acute, subacute, or chronic. We try and determine its size. And these are the normal cutoffs that are used. Something small is less than a centimetre. A moderate sized effusion is between 1 to 2 centimetres, and a large effusion is considered more than 2 centimetres. If it's circumferential, it's tends to be a larger volume, but it can also be loculated. And if it clots in a loculated fashion, it could clot around the right ventricle, the right atrium, and exhibit a lot of compressive effects, resulting in decreased filling, even though it's not circumferential. So that can be quite confusing when you echo these people. If you sample it, you'll be interested to know if it's a transudate, an exudate, blood or air. And clearly, from an intensive care or anaesthetic point of view, we are looking to try and identify its the physiological effects of it. So spotting an effusion, as I said, I'm not going to talk too much about because you've all done Fusic heart before you've done Fusic HD, and the pericardial collection is one of the key things that you're learning to identify on Fusic heart scan. So you all know that the descending aorta, which is seen here, is a kind of like milestone in this view. You can see here, this is the pericardium. Here, this is the pericardium, and there's fluid here, which separates the descending aorta away from the heart. That's how you differentiate it from a pleural effusion. You can see in this case, it's circumferential. It's here, it's anteriorly, and it's inferiorly as well. So very clearly a pericardial collection. You can see it here, and it's, as I said, if it is a lowish pressure effusion that's not circumferential, you'll often see it on the right side of the heart where the pressures are lower, and especially around the right atrium, and you see it quite nicely here. Now, everyone's obsessed with size when it comes to pericardial effusions, and I think that's pretty reasonable. So let me get the size question out of the way. You basically try and determine its maximum width in whatever view you can. So here it's a very small one, it's 5 millimeters. This might actually be physiological. You can see here the aortic valve is open. So this is during the left ventricle ejection phase. So in many ways, this effusion is going to be at its most prominent because it's around the left ventricle. We've already said that left ventricle is, the pressure is at its lowest because the aortic valve is open, so it's actively ejecting, and therefore this effusion that you're seeing here is likely to be its most visible at this time. So very insignificant effusion. This one's closer to 2 centimeters, so slightly more significant here. Again, so this time the aortic valve is closed here, or the mitral valve, I think, is just about to close itself. But yeah, 17 millimeters here, so it's a moderate size effusion, but you would be taking more interest in it because you can see it here and you can see it here. So it is circumferential, and to me the heart doesn't look quite normal either, and we'll talk about some of the caveats around that shortly. This is a bigger effusion. You can see here, this is, it's not clear. This is anterior, so this is parasternal long axis. This is the right ventricle, which looks very kind of weird because it's so nicely defined because there's a fluid collection here. So you're seeing this free wall in a lot more detail than you would otherwise do. So yeah, this is a very large anterior collection, which is overlying the right ventricle. And it's likely to have hemodynamic effects, especially if it's acute. And let's go for the big mama. So this is a 4 and a bit centimeter effusion. Again, parasternal long axis, circumferential. And when you see a effusion like this, you can see that the pericardial wall here is a bit thickened. All this looks a bit abnormal. This is almost certainly, this is a weird thing that's there. This is almost certainly a chronic effusion. It doesn't get to this size without cardiac arrest if it collects acutely. So the patient may be unwell, but they probably won't be catastrophically unwell. You'd see a lot, patients are a lot sicker with 2 centimeters of effusion that have collected within the last 30 minutes. So some videos. I apologize if the frame rate's not good, but again, this is a parasternal short axis view. I can see that the frame rate on my side isn't great, but hopefully you can see it's a swinging heart surrounded by a bag of fluid. And this is, if you're interested in the kind of electrical alternans physiology, this is why it happens, because the ECG electrodes are fixed to the body, whereas the heart is now swinging like a wild thing within the chest, and therefore the axis keeps changing. So this is why you get the weird ECG changes you do in this kind of situation. But yeah, you don't really need to do anything more for this kind of situation. You have a big effusion, the heart looks like it's empty, underfilled, the patient's almost certainly looking terrible, and you just got to get on and stick a needle into it. If you did fancy really running the gauntlet and taking some more images whilst your patient is peri-arrest, you'd find an IVC, which is plethoric. And these patients, I don't know if you see many acute tamponade patients. If they're not intubated, they are breathing at 50 per minute and they're breathing hard. They are properly shot. So this person is working hard from a respiratory point of view to try and overcome any metabolic acidosis that's present. So, in this kind of situation, your IVC gets squished immediately because the work of breathing is so high. Here, in this case, the IVC is static in spite of that high work of breathing. So this is a really important sign that the filling pressure on to the right side of the heart is very high, and there's a blockage somewhere, which is restricting the venous emptying. Now, I think you probably remember we talked about how during the respiratory cycle, the right side fills more or less, depending on what point of the respiratory cycle you're looking at. That's a normal physiological concept that happens with us as we're breathing now. And the harder you breathe, the more that occurs. But here, because of that extra pericardial pressure, when the right atrium is relatively empty, the compressive effects are exaggerated. And therefore, if that happens, there's less volume, and therefore there's less flow through the tricuspid valve. And this can be demonstrated using Doppler. It doesn't matter if you use pulse wave Doppler or continuous wave Doppler, but most usually we use pulse wave Doppler to measure tricuspid valve and mitral valve flow. Here we've taken the horizontal axis, so we can see the respiratory cycle very nicely. And you can see there's a huge variation in E wave velocity. So, this represents the fact that there is an exaggerated filling difference across the respiratory cycle, which we've talked about. Why that is because the right atrium is filling a lot less when the intrathoracic pressure is high compared to the pericardial pressure. So you get this huge variation in flow in spontaneously breathing patients. And when we talk about transmitral flow, in this case, you'd see a variation of over 25%. This is a patient who had cardiac surgery on our unit, and I'll give it away because it's relatively straightforward. This is the pericardial, this white line here, and this is a lovely blood clot, which is right over the right ventricle and right atrium. This patient looks like poo, and this patient shortly goes back to theatre to have that scooped out. But if I may ask, does anyone want to volunteer the obvious mistake in this scenario? And you have to unmute yourself and shout out. No takers? You would think
Taking the cloth for the lever.
Say again?
Mistaking that thinking that the cloth is actually the lever.
No, they clocked it as a pericardial blood clot. So they made the diagnosis right. They did everything right. But I'll tell you what they did wrong. They did a transthoracic echo. So my advice would be never to do a transthoracic echo in a post-cardiac surgical patient. So in this case, they got lucky. They got the glory. Everyone thought they were amazing. The cardiac surgeons didn't, by the way, think they're amazing because they had to come back in and take back to theatre. But everyone else thought they were amazing. But the problem is, if you wouldn't have spotted a pericardial collection with a transthoracic echo, it does not rule it out. In fact, it's up to 50% that are missed with transthoracic echo. So if you want to take home messages in post-cardiac surgical patients, if you're worried about a pericardial collection, don't bother with a transthoracic. If you want to rule it out, you're going to have to do a TOE. Okay? In this case, they got lucky. Right, so let's have a look at this video. Hopefully it'll play. Great. So again, a bit of a no-brainer diagnosis. Don't need anything fancy to say say that this patient needs some intervention, even just from the images, you know. So this is a swinging heart. Everything looks like it's compressed. It's all jiggly jaggly, and it's all a bit of a mess. But if you want to do things properly, you will pause it and slow it down, just in the way we said. So here you can see the tricuspid valve is open. So this is clearly being compressed, this free wall here. But like we said before, if the tricuspid valve is actually open, that compression is just assisting the right atrium in squeezing blood into the right ventricle, which is what its primary function is, let's not forget. So that's not necessarily a bad thing. It's much more important to figure out if there's compression when the tricuspid valve is closed. And here, in fact, there is compression when the tricuspid valve is closed. So, okay, you should be worried about that. That's a problem. And here on this image, you can see that the tricuspid, this is now mid-systole. You can see that the axis of the heart has changed. So it's mid-systole. Tricuspid valve is closed, pulmonary valve is open. But actually, there's no compression here of the right ventricle. So, and if you look here on the image, even though it's swinging around, it's not actually compressing, not being squished shut completely. So here you have, you know, this patient needs sorting out, but there is here compression during the filling stage of the right atrium, implying that the right ventricle is functionally hypovolemic. But the pressure within the pericardium isn't yet overcoming the pressure in the right ventricle, not even when the pulmonary valve is open. So, again, when this is a slightly different table from the one before. So, when you do an echo, you're going to report it in this kind of way. This is the information that you'd want to include in a report. You want to say its size, of course, and that's the maximum size. And you can also say where its maximum size is. You could say at what point of the cardiac cycle that maximum size was measured. On the whole, we tend to standardize hemodynamic measurements at the end of expiration, just so we are standardizing all measurements at one point during the respiratory cycle. But in this case, respiratory variation is important. So if there is respiratory variation, that should also be noted. You want to identify where it is, if it's circumferential or loculated, and again, if it's loculated, where it exists. And here you're going to talk about chamber collapse because you're risk stratifying this patient in terms of the hemodynamic consequences this effusion is causing. So if you have right atrial systolic collapse, so this is the filling phase of the right atrium for more than a third of the cardiac cycle. If you have ventricular diastolic collapse, this is the filling phase of the right ventricle. Left atrial collapse or left ventricle collapse, implying these chambers tend to have higher pressures than these. So if these are being compressed, then these are going to be as well. A swinging heart is clearly a bit of a heart-sick moment, as is paradoxical septal movement. Again, a plethoric IVC implies very high venous pressure, which we know is generally bad. And if you really want to spend some time defining it, you get flow reversal in the hepatic veins as well. And then this pulsus paradoxus, which we've talked about, which is respiratory variation because of this differential filling of the right side. And it affects the right side and the left. The pulmonary circulation blunts the response. But if you have a change of 40% or more flow through the tricuspid valve, compared inspiration to expiration, or 25% through the mitral valve, then that is echocardiographic pulsus paradoxus. Now, a couple of caveats. This patient has to be spontaneously breathing. And of course, the work of breathing is meant to be standardized, but no one has ever talked about what a standard work of breathing is. You can see it if the work of breathing is normal, but if they're panting away and working really hard because they are in low cardiac output shock, then that's not the same as normal breathing. Do you see what I mean? So no one's standardized spontaneous breathing. You can produce minus 30, minus 40 centimeters of intrathoracic pressure when you're working hard, but at rest, it's minus 5 centimeters of water. So clearly not the same physiological circumstances at all. So it's only a still because it was a file that my Mac didn't like, but I'm going to show you this image. And I'd like someone's opinions about what you think of this image. And this is the flow through the tricuspid valve. I beg your pardon? I think it's through the mitral valve. Anyone have any comments? Anything not look quite right? Or is it really clear?
So it looks like you've got a circumferential pericardial effusion that looks moderately sized. Looking at the four-chamber view, it looks like the tricuspid valve is closed. So this is the phase of atrial relaxation, but it doesn't look like there's any compression of the right atrium by the effusion, and it doesn't look like there's any change in the flow velocity through the respiratory cycle. So it looks like there's an effusion without physiological tamponade.
Perfect. Thank you very much, Emma. That's exactly what 99% of the world's population would say, and they would be right. The cardiologists would say the same thing, but we are going to teach you to think like a Back to the Future kind of Doc Brown. Yeah, your job is not only to think about this timeline, but to think about what will happen in alternate timelines, because there's something amiss here. Can you spot anything wrong with the echo? And I apologize, it doesn't move. That makes you worry.
The right ventricle looks big.
Yes, the right ventricle looks big, and this pulmonary vein is chunky. So this patient has long-standing pulmonary hypertension, and long-standing pulmonary hypertension, funnily enough, of course, increases your right-sided pressures. So it protects you from the effects of tamponade, which sounds great. Of course, it isn't, because these patients fall apart very, very easily. So any changes in right ventricular filling, this pericardial effusion would probably have much more significant hemodynamic effects than you would clock from these images alone. So you have to be really aware of things that increase right-sided pressures, because they protect transiently from the effects of pericardial pressure. Okay, so as the right-sided pressures go up, it balances out the pericardial pressures, and it appears like there's no tamponade physiology. So everyone is very happy to watch and wait. But very simple things like tachycardia. Tachycardia is this. No one really talks well. Some people talk about diastolic right ventricular function, but this right ventricle has a disastrous diastolic function. Yeah. So things like tachycardia will reduce its filling. So if this patient got into pain or you try to wake them up after an SBT or whatever, this ventricle is not going to fill, and that's going to change the preloads completely. And suddenly the pericardial collection is going to have a much more significant effect, pressure effect on that now empty, underfilled right ventricle. Similarly, you can induce this kind of problem with PEEP. The patient is on AT of PEEP, and then you put them on an SBT, and suddenly they're shocked because the PEEP was linting their right side open, making the pericardial effusion not significant pressure-wise. But as soon as you remove the PEEP, the right ventricle shrinks back down, and suddenly the pericardial pressure exceeds that right-sided pressure, and you get filling impairments. So you've got to be aware about the changing hemodynamics and what could mitigate your initial interpretation. But yes, on the surface, you would find it very difficult to find a cardiologist who will go and drain this effusion, even though it's circumferential, with these Doppler traces. But you could argue your cause, that there is a reason for it, and it's falsely reassuring. So let's put that newfound knowledge to use. You know, 58-year-old male. I don't know if any of you are anaesthetists and anaesthetized in the cath lab, but AF ablations are soul destroying. I used to do them. So it's a 6-hour buzzing extravaganza on a Friday evening. And of course, as soon as I took the patient to recovery, they were hypotensive. And, you know, I tried to fudge it with some fluid and metronidazole, but they remained hypotensive. Now, when I actually echoed them, I was a little bit shocked because I echoed them before I took the TOE probe out at the end of the case, like I always do. And there was nothing, or there was just a slither there, which is pretty normal. So to find this was a bit of a shock. Now, again, you don't have to be a high-level echocardiographer to apologize. I think internet or my computer is struggling. To identify this as a very large pericardial effusion. You wouldn't bother slowing it down. You would just start screaming until someone stuck a needle into it. The IVC is plethoric. It's circumferential. There's compression all over the place. And you've got the swinging heart signs. So all the bad signs, really. The other thing that echo is good for is to guide a drain. And of course, you have the two standard approaches, which is the zipper-sternal approach, which most cardiologists prefer. But actually, the Mayo Clinic have done the largest series of pericardial drains, 1,200 or so, and they advocate the apical approach. And the 2 or 3 that I've done in ANGA have all been apical. So much more straightforward and a lot less things to pierce. And in particular, if you have a significant tamponade, and especially if it's been going on for a while, one of the consequences of the venous congestion is liver congestion. So the liver tail actually extends across into the zipper-sternum, and I've seen 2 or 3 cases where the pericardial drain has gone through the liver, and not only has the patient then had a pericardial drain put in, but they've also had to have a laparotomy as well to stem the bleeding. So just really be aware that liver congestion, especially if it's been a prolonged effusion, can be a real problem. But here you can put a drain in, you can do a couple of things like stick the wire in and make sure you're in the right space, or you can inject a mil or so of air to make sure that it stays around the pericardium and doesn't go into the ventricle. So there's a number of ways of confirming your drain placement. And then afterwards, as you can see, it looks a lot better. And in particular, what I like was that the IVC suddenly becomes reactive. Right. I appreciate that it's not great. Apologies about that. Let's talk about another case, and I take this directly from an SI at St George's. So it's a 26-year-old who I think it was a night out. He took some chemicals of some description. He got into a fight and got stabbed in the chest. So he had a penetrating wound to his chest, and because of various things that were going on, he was agitated at the scene. So he got knocked down with some more chemicals, but this time dealt by HEMS, and was brought in tubed, hypotensive, and had an echo as part of his primary survey. Now, this is his echo. Samson, I'm happy if you invest in a new computer for me. Gratefully receive it. Hopefully you can see enough of, even though it's clearly not moving as well as I'd like it to. Pericardial effusion. This is probably approaching, these markers are 2, 4, 6, 8, so 2.5 centimeters. This is more than 2 centimeters here. Doesn't that look so significant here or here, but probably it is 2 centimeters here. So overall, a pretty decent volume. Now it's moving. And again, you probably see the dancing trampoline sign on the right ventricle free wall. We also found this, which is a diaphragm and some free fluid within his chest. And we found this. Which is a struggling IVC, but it's pretty compressed, barely there. It doesn't change very much with ventilation cycle. Again, inconsistent with the pericardial collection, perhaps, but consistent with the pleural, presumably blood collection. So he's got mixed pathologies going on here. Okay, so he initially was hypertensive, but then had PAC A, and he stabilized very rapidly. Had a chest drain put in. I think about 900 mils of blood came out, but no, nothing. There was no ongoing bleeding. So he was well. He was warm. He was well perfused. Lactate normalized. His urine output normalized. He was on a bit of NORAD to support his sedation requirements, but everything was really good. And he got a lot of chin scratching and kind of end of the bedo. I'm just going to stand there looking at nothing in particular, but he seemed to be thinking about something at the end of the bed, you know, as is done. And yeah, a plan was put in place. Can I ask anyone who's brave enough to say what they would do? I suppose the two options are drain it or not. So conservative management versus, you know, given its blood and its trauma and its penetrating, really, there's no point putting a drain into it. You'd have to take them to theatre for a pericardial window and drainage. Anyone have any ideas?
I'll stick my hand above the wall. I'd go to theatre and drain it, given the mechanism. It's an acute thing that you haven't got control over, so I'll go to theatre.
Thanks, Alex. So that was my feeling as well. However, after lots of chin scratching and how good he was physiologically after resuscitation, the decision was to manage conservatively. And the reality is, I don't have the repeat echo, which is a shame, but after volume resuscitation, the effusion looked a lot less significant, maybe 1.5 centimeters. They didn't really have any of that chamber collapse, although of course he was mechanically ventilated. So that has an effect on some of that. And, you know, if you read the notes, people documented how the transmitral and tricuspid flows weren't vastly variable, but again, on mechanical ventilation. So either they didn't clock that it wasn't validated in ventilated patients, or they decided to mention it anyway. It wasn't clear. So on the whole, after resuscitation, given how well he was and there was no ongoing bleeding, people decided to manage him conservatively. I'm sensing you sense there's a but coming. So he was looking really good. The next morning, had an SBT. He clearly was a bit hungover, but otherwise, you know, seemed to obey commands and was relaxed and everything was fine. So he went on to an SBT, which he passed, and then got extubated onto high flow. So all good. Then 2 hours later, started ripping things out, and then he went ballistic and started running around the intensive care unit. And then, unfortunately, he got tackled to the ground and then sedated in an emergency. Now, unfortunately, this sedation, because it was an emergency, they used whatever they had and what they were familiar with, involved the evil cardiac drug propofol. And because he was a young guy, strong, fighting, you know, drug and alcohol abuse history, he needed a lot of it. But that, as you know, reduced his preloads, and suddenly that pericardial collection became a lot more significant. And as a result, he arrested and was irretrievable and died. So it's a good example of a effusion which on paper looked moderate, and there was reasonable rationale for why it should be managed in a conservative fashion. However, to me, the missing link perhaps was the failure to anticipate changes in his preloads going forward. And, you know, in ITU, we mess with the preload all the time. Either we aim for negative fluid balances for no good reason, or patients get septic and they get distributive shock. So there's a whole bunch of reasons why RV preload changes. And, you know, in that case, you would anticipate that effusion might then cause a lot more hemodynamic problems. So I just want to reiterate some of the things that we talked about, because these are some of the conversations you'll have, robust conversations at the bedside. The cardiologist will come along and say, I don't want to drain this pericardial effusion. And it's up to you to either agree with that or disagree, and then argue your points methodically and logically. So remember that paradoxus, pulsus paradoxus, is because of this change of filling pressures throughout the respiratory cycle. And it's characterized by greater than 25% blood flow variation to the mitral valve and greater than 45% to the tricuspid valve, but only in spontaneously breathing patients. On patients who are ventilated, no one knows. It is not sensitive or specific, and therefore can't be used. Now, so that's the really important thing. So in positive pressure ventilation, especially if the patient's right ventricle is splintered open, you may not get any flow variations at all. Patients with increased left ventricular filling pressures, so heart failure, aortic regurgitations, loculated effusions, or hypovolemia, as we've seen, may also have absent respiratory variations. Patients who are protected are those with high-sided, right-sided pressures, pulmonary hypertension, called pulmonary, or PEEP. And remember, hypovolemia or high intra-abdominal pressures may actually make the IVC, as we've seen, seem small. And a lot of cardiologists will say, look, the IVC is small, this can't be tamponade physiology. But there's dual pathology going on, but you need to make them realize that. So on the whole, what I would advocate for is to go back to the clinical picture. If you have a shocked patient, and I would argue that a patient, the previous patient, the trauma patient, who required 0.1 of NORAD, was officially on cardiovascular support. So it could have been classified as a shocked patient. If you have a shocked patient with a pericardial collection, I would say that even though the effusion may not be directly causative, it is still hemodynamically significant, and it may become more significant under a set of certain physiological circumstances. So you have a patient with a low cardiac output state, which we've talked about before, hypotension and core peripherales and organ hypoperfusion. But the differences here are the CVP trends up and can trend up quite rapidly. There is often a very dramatic response to volume loading because you are transiently increasing by atrial pressure relative to the pericardial pressure. But it's a transient response, and as that volume redistributes across the whole circulating volume, it becomes less significant, and you get back to the pericardial pressures being more significant. And in my experience, these patients who aren't intubated are working extremely hard from a ventilation point of view to overcome a very profound acidosis, and they are profoundly shocked. And you have a matter of minutes to reverse this. And I really wouldn't bother spending time intubating the patient or putting lines into the patient. The thing that they need, once you spot it, is the pericardium drained. Everything else takes second place. So if the cardiologists and the team as a whole say, we're not going to drain this effusion, then the question is, okay, that's fine, but what will happen? Let's make a contingency plan if things change. So, and we've had another SI at St. George's where we had a moderate effusion after a pacemaker insertion, which was monitored. Now, this patient had hypertrophic cardiomyopathy, so had a restricted filling defect. And unfortunately, when she got septic after 3 or 4 days in hospital, developed a pneumonia, she became tachycardic and had distributive shock. And suddenly, her pericardial effusion looked much more significant. And even if it wasn't causative, it was definitely contributory. So she arrested. It was a catastrophe, and then everyone tried to drain her pericardium there and then, but the cycle of death had already occurred. And even though 900 mils came out, there was no ROSC achieved after that. So who knows what would have happened if that pericardial fluid would have been dealt with in advance. There might have been marginal gains, but it could have made the difference in her outcome. However, so if you anticipate the potential for hypovolemia or the need to get a negative fluid balance in the near future for other reasons, heart failure treatment like furosemide, GTN, or opiates, or you might have high insensible losses, sepsis, tachycardia in patients with diastolic dysfunction, sedative drugs, or an SBT and a reduction of PEEP in the near future, then the pericardial effusion may become a lot more significant. And it's worth having these conversations about these particular contingencies with the cardiologist and advocating for the effusion to be drained before you try or any of these things or before these things happen. So, common mistakes that I have learned from in the past: don't bother with a TTE after cardiac surgery. Go straight for a TOE. If a TE may rule it in, but it cannot rule out a tamponade. So if you don't see it, you're left wondering. And for the team dynamics, it's falsely reassuring. A lack of respiratory variation can be caused by a number of things, ventilated being one and other physiological reasons being others. So don't rely on it. It shouldn't be the be all and end all in your decision about whether this is tamponade physiology. Don't forget things that protect the right ventricle that could be transient: pulmonary hypertension, acute cold pulmonary, or high PEEP. The IVC could be distended and should be, but if it's not, it doesn't exclude tamponades. Again, there could be dual pathology going on. Volume, which the cardiologists will often say, fluid resuscitate the patient, and we'll reassess after that. It's a transient fix. And the cost of it is venous congestion. And we all know that venous congestion is bad. And also it delays intervention. So on the whole, I'm not an advocate for this random fluid loading business when there's clearly a tamponade physiology going on. Think about what potential problems could occur and how a pericardial effusion that's moderate may suddenly become more significant. Think about where you're going to put a pericardial drain, whether it's possible at all, and use echo to help guide its insertion. And beware of liver congestion. Apex may be safer. So, to conclude, tamponade is a clinical decision. On the whole, if you have a shocked patient and pericardial collection, it's probably not helping, and therefore getting rid of it is probably going to be a good thing for that patient. The other smart stuff you can do is icing on the cake, but it does help identify the presence of an effusion, which is the single most important shock, differentiating the cause of shock. If it's obstructive because of tamponade, that's really important. A low pressure tamponade could be significant, so it's important to identify it. Even if you don't drain it straight away, the clinical team need to be very, very clear how it could deteriorate a clinical situation very rapidly. And you can also use echo to insert a drain. And don't forget to learn TOE for your post-cardiac surgical patients. I'll let you screenshot the answers for the questions, so you can go back and have a look at it. And if that's, I've got a reference list here as well. And hopefully Samson's shared a book chapter on exactly this topic I wrote a couple of years ago. So you're all welcome to read it.